Hello class, my name is Dr. Amol Kumar and I am a junior resident in Department of Anesthesia. Welcome to Composed Anesthesia. The topic of today's discussion is spinal anesthesia. So we are going to discuss it in multiple parts and hope you like it and it is informative to you. So let's begin. This is the part 1 of spinal anesthesia. In this we are basically going to cover all the anatomy. So, the vertebral column consists of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal segments. And along with this, there are 31 pairs of spinal nerves. There are 31 pairs of spinal nerves and 33 vertebrae. The cervical has 8 pairs of spinal nerves, thoracic has 12 pairs, lumbar has 5 pairs, sacral has 5 pairs, and coccygeal has 1 pair. So, each pair of spinal nerve emerges from the spinal cord and innervates specific regions of the body. This thing we are going to better understand when we discuss dermatomes. Okay, for now, each spinal nerve they emerge from spinal cord and then they innervate a particular segment in the body. So now we are going to discuss about the spinal cord. So it starts from foramen magnum, okay, and ends at the level of L1 in adults and L3 in children. This is a very important point. Okay, and in adult, the terminal cord, this is called as conus medullaris. The terminal end of cord in adults is called as conus medullaris. So now what happens is the anterior and posterior nerve root, the nerve roots from each spinal segment, they have anterior root and a posterior root, and they both join one another, and then they exit at the intervertebral foramina. Okay, and then after exiting from the intervertebral foramina, they form the spinal nerve from C1 to S5. All right. So one thing is there that here we discussed there are 8 pairs of cervical nerves, but there are 7 cervical vertebrae. Why? So what happens is at the cervical level, the nerve arises from respective vertebra, but after T1, what happens is the nerves start exiting below the vertebra. So if you try to calculate, what happens is there are 8 pairs of cervical nerves for 7 pair of cervical vertebra. Okay, and what happens is that the lower nerve roots they distance before exiting the intervertebral foramina. They don't just exit from the same vertebral level. They travel a distance and then they exit from the intervertebral foramina. And then these lower spinal nerves they start looking like a horse's tail, which is also called as cauda equina. Okay. So now why all this is important? Because the spinal nerve roots and spinal cord they are the target sites for spinal anesthesia. Okay. In this diagram we are going to see the phylum terminale. This is the phylum terminale, and we are also going to see conus medullaris. This is the conus medullaris. Conus medullaris is the point at which the spinal cord ends in adults, and here is these we'll discuss it further, but these are the spinous processes, and then there are various ligaments which we'll see later in the class. Moving on, this diagram is very important as it shows the anatomy of a vertebra in two views. This is the superior view when we see it from above, and then this is the lateral view, which means we view the vertebra from the side. In superior view, we can see the parts of vertebra as there are two processes. One is on the lateral side, this is a transverse process, and one is facing anterior, this is the spinous process. So spinous process, transverse process. Then there is this thing lamina. It connects the spinous and transverse process on each side. Okay, and this is the pedicle. Pedicle attaches the transverse process to the body of the vertebra. All right, and when we see this in the lateral view, we see that this is the body of the vertebra. This is the pedicle. Okay, and pedicle has notches above and below. These notches form the intervertebral foramina. Okay, and this is the spinous process. And then we can see there are two articular processes which articulates with above and below. One is the superior articular process, and other is the inferior articular process. We'll just go through once. There, okay, and this we see here. This thing, these are called the intervertebral disc. What do they function as? The adjacent vertebrae are joined through them, and okay. So intervertebral discs they connect the individual vertebral bodies and they lie between the vertebral bodies. Then we have facet joints. There are 4 small synovial joints per vertebra, 2 superior, 2 inferior, and they lie adjacent to the transverse process. Okay, this is the transverse process, and here is the articular process. Then we have pedicles. Pedicles are notched superiorly and inferiorly, and these notches form the intervertebral foramina. What does intervertebral foramina do? It opens. It is the opening through which the spinal nerves exit the spinal column. Okay, and then we have sacrum and sacral hiatus. The sacral hiatus is the caudal opening of the spinal canal, and how it is formed? It is formed by the infusion of laminae of S4 and some S5 and sometimes of S4. Okay, this we'll discuss in detail when we discuss about the caudal epidural anesthesia. Next, this is a very good diagram. Okay, this diagram shows you the various ligaments. So if we have a good understanding about this diagram, we can actually see that when we put spinal needle, when we insert a spinal needle for spinal anesthesia, what are the layers which we go through? Okay, so here is the spinous process. The first ligament you see is the supraspinous ligament. So I'll show you the supraspinous ligament. This ligament exactly, the ligament, the most anterior ligament which is connecting the two spinous process. Okay, it basically connects the apex of the adjacent spinous process. Okay, and this is also known as ligamentum nuchae. When you see this same ligament above C7, this same ligament is called as ligamentum nuchae. So this is after this we see another one big chunk of ligament. This is also connecting the two spinous process, and thus it is called as interspinous ligament. Okay, and after this we can see a small yellowish ligament in this diagram. This ligament is called as the ligamentum flavum. What does it do? It connects laminae. So the supraspinous and interspinous ligament, they connect spinous process. The ligamentum flavum connects lamina, and then we can see there are two ligaments. This ligament is the posterior longitudinal ligament, and this is the anterior longitudinal ligament. What do these two ligaments do? These two ligaments binds the vertebral bodies together. Okay, so like if you want to insert a needle, you're going through this. You're going to through this. So the first layer you involve is skin. Then you see obviously you're going to involve the subcutaneous fat. But the first ligament you're going to encounter is the supraspinous ligament. After supraspinous ligament, you are going to encounter the interspinous ligament. After interspinous ligament, you are going to encounter the ligamentum flavum. Your needle is going like this: supraspinous ligament, interspinous ligament, and ligamentum flavum. After the ligamentum flavum, what you are going to pierce is the dura mater. After dura mater, the space which is after the dura mater is the subdural space, and after the subdural space, you are going to find the arachnoid matter. And as soon as your needle goes through the arachnoid matter, you are into the subarachnoid space, and that is the target point where you have to reach and deliver your spinal anesthesia drug. So this shows you this it has just summarized what I have just said: the supraspinous ligament, the interspinous ligament, the ligamentum flavum, the posterior longitudinal ligament, and the anterior longitudinal ligament. Okay. So this this diagram is specifically to show you the layers of the membranes which you have to pierce while you are injecting the spinal anesthesia. So the most outermost layer is the dura mater. After that, there is subdural space. Then there is arachnoid matter. This outermost layer which you see, this is the dura mater. After that, you see this arachnoid matter, and then there is this pia mater. The pia mater is different from dura and arachnoid in a way that pia mater is actually adherent to the spinal cord. So what happens is the dura mater and arachnoid matter, they end at the S2. But however, the pia mater does not end at S2. They go up till the phylum terminal. They go along with the spinal cord till the phylum terminal. So here we have discussed the same thing. So we will try to discuss a summary of what layers you are going to pierce when you give a spinal anesthesia. So first, you are going to pierce the skin. Okay. Then you are going to pierce the subcutaneous tissue. What is the first ligament we are going to pierce? We are going to pierce the supraspinous ligament. This is the ligament which holds the tip of adjacent spinous processes. Then we are going to encounter the interspinous ligament. This is also the ligament which holds two spinous processes together. Then we are going to encounter the ligamentum flavum. Remember the yellow ligament? And as soon as you cross the ligamentum flavum, you are going to reach the dura mater. After dura mater, we know there is subdural space. Then there is arachnoid matter. And then finally we reach our destination, that is the subarachnoid space. This is very important to memorize. It is most commonly asked in the OTs by our consultants and also during vivas and obviously in exams. So I hope we have a better understanding about it now. Okay, but all, here is the summary of layers which are transversed during spinal anesthesia. We'll discuss it again later. But for now, we have discussed only the midline approach. There's another approach that is a paramedian approach. What you do that is you go 1.5 centimeter lateral and then you inject. So here you are going to bypass all the ligaments which are connecting the spinous process and the lamina. So you are directly going to encounter the ligamentum flavum after going through the paraspinous muscle, and after the ligamentum flavum, the sequence remains same: the dura, subdural space, arytenoid, and the subarachnoid space. Alright, these are the normal curves which are found in everyone. Okay, the cervical spine is bent anteriorly, the lumbar spine is bent anteriorly. So, both of them are lordotic. Something that is bent anteriorly, it is lordotic. Both cervical and lumbar are lordotic. However, the thoracic spine, it is bent outwards. So, it is kyphotic. These are the normal curves present in the spinal column. So, next we see the surface anatomy. This is the most important line that we palpate. The line passing, imaginary line passing through the superior, through the most superior point of iliac crest that corresponds to L4. Its name, it is given a name. It is called as Trophius line. Okay, and then we have this line which passes through the inferior tip of scapula. This line corresponds to T7, and there is a line that passes through the most prominent cervical process. This corresponds to C7. So we have C7, T7, then the Trophius line which corresponds to L4, and finally one line which passes through the both PSI, that is posterior superior iliac spine, that corresponds to S2. Now we have this thing, this figure. This is a very this figure shows the dermatomes. What are dermatomes? So basically, the spinal nerve innervates a segment of the body. So each segment innervated by spinal nerve is a dermatome. Okay, like for example, this area, this is the area around the nipple. This area around the nipple, this is supplied by T10. Okay, around the not nipple, around umbilicus. Around umbilicus, it is a T10. Then this is around the nipple. This is supplied by T4. Okay. Then we have an area near the xiphoid process, that is approx the area near the xiphoid process that corresponds to T6. So after you give a spinal anesthetic, so you require a specific level for specific surgeries. Okay, for example, for an upper abdominal surgery, you need a T4 level. For intestinal, gynecologic, and urologic surgery, you need T6 level. For TURP, you need T10 level. For a vaginal delivery of a fetus and hip surgery, you need T10 level. For a thigh surgery and lower leg amputations, you need L1 level. For a distal surgeries like foot and ankle surgery, L2 level is enough. Okay, and for some surgeries which involve perineal and anal surgeries, you don't need to achieve a very high level. A level S2 to S5, that is also called a saddle block, that is enough. We are going to discuss about the saddle block later in our class. So now coming to the last topic of anatomy, that is the blood supply of spinal cord. So we can see, first we will try to see identify the arteries. There is a anterior spinal artery. Okay, this is anterior spinal artery. Anterior spinal artery is single. Then we have posterior spinal artery. This artery is paired. It is not single. Anterior spinal artery, you can see it arises from, this is the vertebral artery. It arises from the vertebral artery. Okay, and how much does it supply? It supplies the anterior 2/3 of spinal cord. Okay, and what does this posterolateral supplies? It supplies the posterior 1/3 of spinal cord. Okay, so both these arteries, they also receive some additional blood supply, and both receive an additional blood supply from intercostal arteries and also lumbar arteries. So we have anterior spinal artery which is single, we have a posterior spinal artery which is paired. The anterior spinal artery arises from the vertebral artery. Okay, and where does posterior spinal artery arise from? It arises from the posterior inferior cerebral arteries. Okay, and both of them also have an additional anterior spinal artery supplies the anterior 2/3 of spinal cord. Posterior spinal artery supplies the posterior 1/3 of spinal cord. Both of them also receive some additional blood supply from the intercostal arteries and the lumbar arteries. And one artery of interest that I want to discuss here is the great ventral radicular artery, also called as artery of Adam Kivish. So where does this arise from? This is a very important artery which arises from the aorta. Okay, and it is a major blood supply to anterior lower two-thirds of spinal cord, anterior lower two-thirds of spinal cord, and it is usually on the left side. Okay, so what implication does it have? When you are giving a paramedian approach, you usually go through the right side, and if you go through the left side, there is a risk of hitting this artery, and its injury can definitely cause a condition that is called as anterior spinal artery syndrome. So this is our part one. Here we discuss the anatomy of the vertebral body, vertebra. We have discussed the anatomy of spinal cord. We have discussed all the ligaments, and also we have discussed the blood supply, the dermatomes. I hope this class is useful, and we can connect this anatomy to the further topics which we are going to discuss later. So thank you, and see you again.